Welcome back to RN Toolkit. Today we're covering the eye assessment, including anatomy, reflexes, age-related changes, and vision disorders like cataracts, macular degeneration, and glaucoma. This is perfect for clinicals and NCLEX prep.
Here's our game plan. We're going to start with the eye's anatomy, kind of like its blueprint. Then we'll see how it actually works, how it changes as we get older, and what happens when things go wrong with common diseases. We'll wrap it all up with how we can help people keep their vision sharp for life. You ready? Let's get into it. Seriously, have you ever just stopped to think about this? This little 1-inch ball, it creates everything we see. It's tucked away safely in its bony socket, and yet it's feeding our brain more than half of all the information it gets. It's just mind-blowing, right? So how in the world does it do that? Well, it all starts with the basic parts. Okay, first up, a tour of the eye's anatomy from the outside in. Look, you've got to know the map before you can explore the territory, right? Nailing these structures is the foundation for everything else. It's how you'll know what looks right and, crucially, what looks wrong. So when you first look at someone's eye, what you're seeing is basically a protective shell. Everything here is designed for defense. You've got the palpebral fissure. That's just the space between the eyelids. You want to check that for symmetry. Then there's the conjunctiva, that super thin, clear membrane. That's your go-to spot for checking for redness or inflammation. And of course, the lacrimal apparatus. That's the tear factory and drainage system, keeping everything lubricated. And you know how common dry eye is, so it's a big one to ask about. Okay, let's peel back that first layer. We see the sclera, that's the tough white part, and the cornea. Now, the cornea is super interesting. Yeah, it bends light, which is its main job, but it's also one of the most sensitive parts of your body. If you touch it, you get an immediate blink. That's the corneal reflex. And here's the clinical pearl you need to remember for exams. This isn't a one-nerve job. The trigeminal nerve, that's cranial nerve V, feels the touch, and the facial nerve, cranial nerve 7, makes you blink. Sensory in, motor out. Super important. All right, diving a little deeper now to the middle layer. Think of this as the eye's plumbing and machinery. It's vascular, meaning it's packed with blood vessels. You've got the choroid, which is dark to stop light from bouncing around all over the place. The ciliary body, those are the tiny muscles that change the lens shape for focusing. And then the iris, you know, the pretty colored part. It's literally the eye's camera aperture, opening and closing the pupil to control exactly how much light gets to the back of the eye. And now for the grand finale, the inner layer. This is the neural tissue, the retina. This is where the magic really happens, people. It's like the film in the camera, turning light into electrical signals the brain can understand. When you peek through an ophthalmoscope, this is your view. You're looking for that optic disc. That's the head of the optic nerve. It should have a nice, healthy, creamy yellow color. You'll trace the blood vessels, and you'll zero in on the macula. Remember the macula? That's the VIP area, responsible for all our sharp, high-definition central vision. Okay, so we've covered the hardware. Now let's talk about the software. How does all this stuff actually work together to let us see? We're going to get right into the reflexes you'll be testing every single day. Your pupil size is in a constant tug-of-war between two systems. It's pretty simple to remember. You've got the sympathetic system, that's your fight-or-flight mode. If a bear is chasing you, you want your pupils wide open to let in as much light as possible, right? That's dilation. Then you have the parasympathetic system. Think rest and digest. When you're chilling out, reading a book, your pupils constrict to help you focus up close. It's a beautiful little balancing act. And that brings us to the classic pupillary light reflex. You do this all the time. You shine a light in one eye. What happens? Well, the optic nerve, that's cranial nerve 2, senses the light and zips a signal to the brain. The brain then tells the ocular motor nerve, cranial nerve 3, to take action. And here's the cool part. The signal goes to both eyes. So the pupil you're shining the light on constricts. That's the direct response. But the other pupil constricts too, and that's the consensual response. It's a fantastic way to check if that whole pathway is working. Okay, 2 more reflexes you absolutely need to know: fixation and accommodation. Fixation is exactly what it sounds like. It's your eye's ability to lock onto a target and keep it centered on that high-res spot, the fovea. Accommodation is the eye's superpower for near vision. Just watch someone's eyes as they look from something far away to something up close. You'll see 2 things. Their pupils get smaller and their eyes turn in just a little bit. That's accommodation. Okay, get ready for a fun fact that might just blow your mind. The picture that the lens projects onto your retina, it's completely upside down and backwards. No, really. So why isn't our world a mess? Because our amazing brain, the occipital lobe, way at the back, flips it right side up for us in real time. How cool is that? All right, let's talk about how the eye changes over a lifetime. It's really important to know what's just a normal part of getting older versus what's a sign of disease. You've definitely seen this one, presbyopia. It's the reason why, somewhere around their 40s, everyone starts holding their menu way out to read it. It's not a disease, it's just aging. The lens inside the eye, which used to be all soft and flexible, starts to get stiff, kind of like old glass. It just can't change shape as easily anymore to focus on things up close. Hence, the reading glasses. And you're going to see a bunch of other things in older adults that are totally normal, so don't freak out. Their eyes might be a bit drier because they make fewer tears, their pupils might be a bit smaller, or react a little slower. They might lose some eyebrow hair on the outside, and those annoying little floaters they complain about, usually just the vitreous humor clumping up. The big takeaway here is knowing that these are just signs of a well-used eye, not necessarily a diseased one. Okay, but sometimes the changes aren't so harmless. Now we're going to shift gears and talk about the big 3 diseases that cause serious vision loss as people age. And trust me, you have to know the difference between these. It's a huge deal for your patients and, yep, for your exams too. This slide is gold. The key to telling these 3 apart is the type of vision they steal. Just remember these images. Cataracts, that's like trying to look through a dirty, foggy car windshield. Everything is just cloudy and blurry. Macular degeneration, or AMD, attacks the center. It's like a smudge right in the middle of your vision, so you can't see faces or read a book. And glaucoma? That's the scariest one. It's the silent thief. It sneaks in from the sides, stealing your peripheral vision, and you often don't notice a thing until it's way too late.
And just to drive home how sneaky glaucoma is, look at this number, 7 times. That's how much more common the quiet, open-angle glaucoma is compared to the kind that causes sudden pain. This is why we scream. Patients won't feel it. They won't know what's happening. We have to be the ones to catch it because once that peripheral vision is gone, you can't get it back. It's gone forever.
Okay, so this brings us to the most important part of all. What do we do with all this knowledge? Let's talk about how we can actually help people protect their sight for their whole lives. So what are our marching orders? First, remember that a lot of vision problems are just people needing the right pair of glasses. It's that simple. In kids, we gotta be on the lookout for strabismus, a cross eye, so we can prevent it from turning into a permanent lazy eye. And for adults, especially those at higher risk, we have to push for glaucoma screening because, as we know, it has no early symptoms. And the thing we must get across to every patient is this. Treatment can slow things down, but it can't bring back what's already been lost. I mean, this quote really nails it, doesn't it? Early detection is everything. With these slow, progressive diseases, our best and sometimes only weapon is catching them early. The sooner we find it, the better chance we have of saving the vision our patients still have. So I'll leave you with this question to take with you. Now that you've got this deep dive into how the eye is built, how it works, and how it breaks, what are you going to do with it? How are you going to use this to protect your patient's sight? That's what it's all about.